kneecap issues?
Just crepitation sound.
Crepitus sound? Is that going on?
Yep.
Yeah, very slow.
Okay. So, patella accessory movement. So first of all, you've looked at the patella in standing, and now you're going to assess the patella in supine, and you've checked for swelling, and we already know that history of a lot of swelling, particularly intra-articular swelling, is suggestive of a patella dislocation. So when it comes to patella dislocation, we're actually going to do the tests in a particular order. So exactly the same as we just had a discussion about when would you do this. If you are suspicious of someone dislocating or significantly subluxing their patella as their source of pain, I wouldn't necessarily do these tests now. I would do them in a more structured way, which we will go through later. This might be useful. So we're talking about, do you mobilise the tibiofemoral joint in someone who's had a total knee replacement? No, because we know that the tibiofemoral joint has got nice, smooth, shiny surfaces, and that's not the source of the stiffness anymore. It was before, but it's not now. With that total knee replacement, when you have the original patella in place, that can be a source of stiffness, because if the patella can't glide up nice caudally and cephalad with knee flexion extension, that stiffness there can then translate to limited knee flexion or extension, mostly knee flexion. So if you have a lot of swelling, which we do when people have a total knee replacement, that can sort of consolidate around the patella and make it quite stiff. So you want to assess those movements. You also, if we're talking about patellofemoral pain, might be assessing whether someone has good patellar mobility, particularly medially, because often they have nice tight quadriceps, particularly a dominance of the vastus lateralis. So with your handling of the patella itself, you want to stabilise the femur and the tibia, because you're trying to move the patella on top of that. So you don't want to kid yourself or trick yourself that you're getting extra movement, but it's coming from the tibia. So with this, have just again that anatomical neutral, trying to get to the foot to neutral, and then from this position I'm going to apply a medial glide of the patella. Now you're doing a fabulous job. They obviously have to be relaxed. If you squeeze your quads for me, obviously I'm not going to be able to move that. Okay, so if we go with a nice relaxed patella position, again your relaxation is being cued by your good handling here, and we're doing a medial glide. Now it is important when you medially glide that you're moving evenly inferior and superior thumbs, and you're going across the top, not down into the knee. So I'm not pushing doing this, and also it's a glide across the top instead of a tilt. Does that make sense? So I want to see if they can glide medially, and does it feel the same on both sides. Once it's been moved medially, you may try a medial tilt if you feel that they are sitting with the patella laterally, and that might be the case if they have tight lateral structures sort of holding down there. So you can move across, hold, and then do a medial tilt there. If often in patellofemoral cases where there's an element of tightness or stiffness, it may be very difficult to feel even under that lateral border of the patella, because those lateral structures are so tight. So medial glide, medial tilt. Then we're going to do a caudad and cephalad glide. So caudad. Now with these ones, get your arms down nice and low along the line of the tibia and the femur, because then you know that you're just moving the patella up and down that way. So in that position, caudad, cephalad. okay? And you're getting a feel of the mobility there. And feeling amongst you all, there's not a lot of movement up and down, but there is some movement. So if you have someone who is not getting any movement and there's swelling around there, you may spend some time working on their patellar mobility to then reassess what their knee flexion range feels like. You can also do a lateral glide. Now again, this is we're taking care with our history and also the current presentation that that's not going to sublux. So I'm doing this on someone who I don't have any history of subluxation or dislocation, and doing it with nice gentle movement, and then even someone who's stiff, you're quite confident that you can push that quite firmly. And you'll get a little bit more, I can access underneath that patellar facet quite nicely, which can also be helpful when it comes to palpation around the patellofemoral joint. So we also, patella, going to assess the glides here. Next thing you're going to do is assess the superior tibiofibular joint, okay? So I'm going to sit on your foot. Sorry, people. Back to you. So the line of the superior tib fib joint, so the fibula on the tibia, is you're going to go posteromedial, anterolateral. So it's up on the notes. So I'm gripping onto the fibula head with the soft bit of my finger here, not poking with my fingertip. Remember, you've got your common perineal nerve around here, so you don't want to be annoying that. And my thumb, I'm nice and broad on the distal phalanx. So I'm sort of gripping it like that, but it's nice and soft and broad. Don't be too pokey. So don't do this, because they won't be able to relax into it. The other thing is, you've got your hamstrings attached and your ITB attaching into that superior tib fib. You want to make sure they're nice and relaxed, because otherwise you're not going to get any movement there. So just stabilising the femur tibia with this hand nice and gentle around the superior tib fib, and go posteromedial, anterolateral. And in some of you, you'll feel quite a bit of movement. So don't jam onto it, because then you won't feel anything. Try and be a little bit gentle and see if you can get any feeling of glide there. Posteromedial, anterolateral. Lovely. Now if you flip over onto your stomach. Oh yes, sorry. You're right for the patella glides? Yeah, that was all right? Just this one? Yeah. So, superior tib fib, holding on, try and make sure this is nice and relaxed. Stabilise the femur and the tibia with this hand, and then it's posteromedial, anterolateral. Posteromedial, anterolateral. So you actually got a bit more movement on this side compared to the other side. You can feel that there. Yeah? Can you feel that movement a bit more? Yeah. So that's that one. Then flip over onto your stomach. So the other way that the superior tib fib joint can be involved is if you've had an ankle injury or an ankle sprain here. So if that inverts and tractions on the distal aspect of the fibula, you may get a secondary injury or fracture at the fibula head. So this is obviously not screening for fracture, this is just, does movement of the ankle bring on their lateral knee pain? So we're thinking about moving the ankle to affect the distal, the proximal fibula. Now in this instance for this test, the ankle joint needs to be uninjured, because what we're doing is doing a tilt of the ankle so that we're moving the distal fibula to pull on the proximal fibula. So we're doing a inversion to glide the superior tib fib joint towards the foot, and we're doing an eversion movement to glide the fibula in a cephalad towards the head approximately. So it's that movement and that movement. But obviously if you've got an ankle sprain, you're not going to be able to do that. So it would want to be a clear ankle sprain before you could do that. And you're looking for reproduction of symptoms at the lateral knee. You're not looking for what happens here. That's just the lever that you're using to get there. Okay, so can you practice patellofemoral glides, so patella glides, and superior tib fib in AP and chordad cephalad? Thank you.